Good evening, everyone. Welcome to our HipecTreatment.com live Q&A session. My name is Glenn Keeling. I am the administrator for HipecTreatment.com. And the live Q&A session tonight is Hipec and the state of science for abdominal and thoracic carcinomatosis. I would like to introduce our distinguished panel from the University of Miami, Möller School of Medicine, Dr. Moller, surgical oncologist. Dr. Sinno is a gynecological oncologist, and Dr. Villamizar is a cardiothoracic surgeon at the University of Miami School of Medicine. So to start the questions, if there's any questions from the audience, let them come in. Dr. Moller, first question would be going to you. Can you tell us about your program at the University of Miami? How long has it been in existence? And what type of patients do you treat as a surgical oncologist?
The Hipec program at the University of Miami was actually the first program in South Florida, and we are a recognized National Cancer Institute, one of the centers recognized as an NCI center. And we had been for about 10 years. So we had treated more than 300 patients in their in the program. And from the surgical oncology standpoint, we treat patients with peritoneal carcinomatosis from appendiceal mucinous neoplasms, so appendiceal cancer, pseudomyxoma peritoneae, mesotheliomas of the abdomen, some type of mucinous tumors from the colon, gastric carcinomatosis in selected cases, round cell tumors, and basically those are the main tumors that are treated with Hipec.
Okay, Doctor, as a gynecological oncologist, what kind of patients do you treat with Hipec?
So as gynecologic oncologists, the patients that we see most often for consultation for Hipec treatment are patients with ovarian cancer, specifically high-grade serous ovarian cancer and other forms of epithelial ovarian cancer. Patients are usually either in the upfront setting, meaning they just got their diagnosis, or they come in with carcinomatosis and have in the first stage prior to any treatment, prior to any surgery, or we see them after they've been getting some neoadjuvant chemotherapy, which is when patients get chemotherapy prior to surgery. So they get 3 cycles or 4 cycles of chemotherapy to reduce tumor burden, and then they get referred to us often for debulking surgery and Hipec. And then patients go back to their treating oncologists for the chemotherapy if that's how it happened. And then the other situation where we see patients for Hipec is in the recurrent setting, as long as they meet very specific criteria that allow us to perform surgery in these patients. So there are certain criteria that patients have to, and their tumors have to meet for them to be good candidates for Hipec. From a medical point of view and from a surgical oncologic point of view.
Dr. Villamizar, as a cardiothoracic surgeon, what type of patients do you treat?
So with the heated chemotherapy, we treat cancer of the pleura, which is the lining of the inside of the ribs and the outside of the lungs. And then that cancer is called mesothelioma. And also we treat thymic malignancies, either thymoma or thymic carcinoma that has metastasized to the pleura.
Okay. As far as cytoreductive surgery is concerned and Hipec, Dr. Moller, could you explain what these mean? What is Hipec and what is cytoreductive surgery?
Dr. Moller, I think you're on mute.
Cytoreductive surgery is the same as debulking, basically. And what it means is that we remove all the tumors that we see into the abdominal cavity. Basically, every metastasis that we can resect, we will do resect. And sometimes that require removing certain organs because it's not just possible just to remove the tumor. We have to remove the tumor that is alone, that maybe that carcinomatosis is wrapping around that organ. We have to remove that. And we want to achieve that, what it's called, you will see some people say R0. R0 means we want to remove every single tumor that we can see with our naked eyes. That is an R0 resection. And in addition to that resection, we do the Hipec. So even though people say Hipec just as a general name, in reality, the surgery is a two-part surgery. The first part is when we operate for multiple hours, and could be several teams. It could be me and Dr. Sinno and the colorectal team, as well as sometimes we had Dr. Villamizar as well, to do certain areas of the resection. And once that we complete that could take up to 12 hours. Then we go and provide we proceed to the next step, which is doing the Hipec, which is when we put catheters connected to a machine that heat up the solution, heat up the chemo, and we recirculate for about 90 minutes. So those two things is what make it be successful, is the many hours trying to remove tumors and then put in the Hipec to take control of whatever microscopic cells are left behind that we couldn't see.
Dr. Moller, who is a candidate for cytoreductive surgery and Hipec?
Well, in my case, it's very different for me, for Dr. Sinno, and for Dr. Villamizar, because we treat different diseases. Our Hipec program is a combined program, so it's just not for only one specific disease. That's the beauty of our program, that we have multidisciplinary care. In my case, in my particular case, the good candidates are patients who tumor has spread into the abdominal cavity. However, is what we consider is still resectable, means it has not invaded into organs that we cannot remove. There are specific areas when for us is no longer a resectable candidate. For example, if the tumor is wrapped around what is called the porta hepatus, which are the vessels that go to the liver, and that part in that area, we cannot remove that because we will have to remove the liver. When the retroperitoneum is completely plastered to the ureters and the kidneys, that's a patient that usually is not a resectable patient. Or patients when the root of the mesenteric is like an apron the bowel is connected to it and has the blood vessels to the bowel. When that root of the mesenteric is encased with tumor, that is considered not resectable. Or when there is the entire small bowel is full of carcinomatosis, we cannot do that because a person cannot live without their bowel unless they get a bowel transplant. And in this setting, that is not indicated. So if we cannot remove the entire tumor from the small bowel, that is considered not resectable.
Okay.
So
Dr.
I will let Dr. Sinno and Dr. Villamizar continue with what for them, for the type of patient they treat.
Okay. Dr. Sinno?
Yeah, so for ovarian cancer surgery, ovarian cancer is very specific in that it's often sensitive to chemotherapy. The role of surgery in ovarian cancer, and frankly, the role of expert surgery in ovarian cancer, cannot be overstated. There's a lot of data that shows that when you have ovarian cancer surgery is done at specialized centers, at NCI designated cancer centers, at high volume centers with gynecologic oncologists, that the outcomes in survival, progression, and overall survival are superior. The reason for that, the reason for these differences in outcomes between where a patient gets treated and are because of the fact that ovarian cancer is a very different kind of cancer than some of the peritoneal malignancies. The way it's different is that you really need to achieve an R0 resection. So nationally, we call optimal cytoreduction any time you're able to, in ovarian cancer, anytime you're able to reduce the tumor burden to less than a centimeter. But for us here at University of Miami, what we consider optimal is R0, meaning there's no residual tumor. And so a patient who is a good candidate for Hipec is a patient that we can get to R0 surgically with our multidisciplinary approach. So if there's tumor on the liver, we operate on the liver. If there's tumor on the spleen, we'll operate on the spleen. If it's small bowel, large bowel, bladder, ureter, wherever it is in the human body, we can, as long as we are able to resect it safely, then we will do so. And the other really important thing is looking in the areas where they're not clearly visible. So we have to open up areas in the abdomen that are otherwise not visible unless you go dissecting for them to make sure that you resect all the tumor. So a good candidate is someone who is a good candidate for surgery to get them to R0. Number two is medically fit for surgery. So we have a plethora of data now that patients who are frail, and that's the medical term for patients who are not fit for surgery. Their performance status maybe is poor. There's a frailty assessment that we do on every patient prior to taking them to the operating room. So we do a full 360-degree frailty assessment and to stratify if this is someone who will do well with debulking surgery, let alone adding the Hipec on top of it. And then the patient has to be sensitive to chemotherapy. So if someone is failed primary chemotherapy within less than 6 months, then that's someone who has disease which is not sensitive to chemotherapy for ovarian cancer. And that patient would not be a good candidate for the Hipec procedure. Finally, non-ovarian cancer is still very investigational. We are planning to open a trial for uterine serous carcinomas and Hipec, but cervical cancer and other uterine cancers, those are not candidates at this point for the Hipec procedure.
Okay. Dr. Villamizar, as far as
so in terms of mesothelioma, of the pleura, we would consider a candidate for surgery if the mesothelioma is confined to a single hemithorax, meaning that is either on the right side of the chest or on the left side of the chest, but we wouldn't do that if the mesothelioma is in both, surrounding both lungs, for example. Or if it is in the chest and in the abdomen, it would need to be very selected cases, extremely young patients, that kind of thing. And that would be a multidisciplinary conversation with Dr. Moller that we would entertain such an aggressive surgical approach. And once we determine that the cancer is confined to the hemithorax, then we need to do some what we call staging imaging studies. We typically do a PET-CT to make sure that there is no evidence of cancer anywhere else. Then we have to make sure that we don't have like the lymph nodes in the middle of the chest on the other side that are involved. We need to make sure that it's not invading through the ribs in multiple ribs, that we will need to basically remove a big portion of the rib cage to get the tumor out, or that it is not invading like the major vessels in the chest, such as like the aorta and the cava and that kind of thing, that we would consider that too aggressive of an approach for this disease. So there are several studies that we need to do in terms of the this resection. In the past, it was advocated to remove the entire lung, the lining of the heart that is called the pericardium, and the diaphragm, but nowadays we favor just to remove the lining and keep the lung intact, which is a more difficult operation to do, to spare the lung, and then we always need to do what we call like pulmonary function tests and kind of have an idea of whether a patient could lose the entire lung if it arrived to that there were like tumors that we couldn't just peel off the lung, but we had to remove the lung. So those are the main things that we look for. Of course, this is a very aggressive in a way surgical procedure, and the younger the patient, the better it is. Typically, I tend to shy away from doing this surgery in the chest in patients that are older than 75 years old, unless, again, exceptionally excellent performance status, because it is a hard surgery to recover from.
Dr. Moller, what can these patients expect after surgery? Do most of the patients end up with a colostomy?
Not necessarily. There are, in reality, a very few patients in there with a colostomy. And some of them actually is a temporary colostomy. If we find that there is tumor down in the pelvis and involving the rectum and the anastomosis, which means the reconnection is too low in the pelvis, then we do a temporary ileostomy to let the anastomosis heal, and then the ileostomy is put back. We will leave a colostomy. Usually it's like in extreme cases when we had done maximum debulking and that was the only option left for us. But we try to reconnect these patients because we know it's better to reconnect them because they have better quality of life and the nutrition is more manageable with these patients. Now, what should I expect? Obviously, for each of the three of us, the protocols of recovery are slightly different because of the organs that we do or because of how we manage. We have a universal protocol that we use for our patients. We have a rapid recovery protocol for all our patients that come for a Hipec. They get actually a pre-screen from a team of anesthesiologists to optimize them. We optimize their nutrition. I refer these patients as well to the rehabilitation, pre-cancer rehabilitation, so they can start getting strong before the surgery. So we have a team, we have the surgical nutrition team, the rehabilitation team, the anesthesiology team that will see these patients before we go to surgery. And our intent is that under this protocol that is called ERAS, these patients get discharged from the hospital quickly. The average for our population of our patient is actually between 8 to 10 days in the hospital. Of course, there are patients that could go way longer than that and patients that can be discharged even sooner than that. But the average is around 8 to 10 days. But it will depend on what organs were removed, if they were drains, that they were different anastomosis. So it's dependent. But that is, if everything goes as expected, usually the patient will be in ICU for the first 48 hours, mostly because we have to monitor the kidney function so they can wash out the chemo. And we actually, our protocol, we extubate the patients after the surgery. And they go there just for that monitoring, and then they go to the floor, and we expect these patients to be walking around the day after the surgery, to be moving around, and we very expedite removing the nasogastric tube and getting them feeding. And we have been very successful with that protocol and getting patients discharged safely to home.
You know, Glenn, one of the things that varies a little bit between the different cancers is that a lot of the ovarian cancer patients that I see are referred to me after they've started chemotherapy with their medical oncologist or with their own physician. And that window of getting chemotherapy prior to surgery, I can use that window to optimize the patient. So for patients who are getting neoadjuvant chemotherapy, I can't overstate how important what Dr. Moller was talking about. That's 21st century surgical treatment. It's not like in the old days where the surgeon shows up, makes an incision, does what they need to do, and then leaves. Like most of the work for surgery gets done prior to surgery so that the patient can have a quick recovery afterwards. So we actually get the patients, to increase their exercise. Look, think of it this way: would you tomorrow? You're in shape, but let's say you weren't in shape. Would you just go and run a marathon tomorrow? No, you wouldn't. You'd have to train for it. And it's the same thing with surgery. You don't just show up to surgery. We get your body ready to tolerate the surgery to prevent complications, whether they're infectious, pulmonary, GI, all that stuff. So we do the prehabilitation, the nutrition, all that, and we use that window. It's called prehabilitation, and we have an excellent center for. It's one of the best I've seen at prehabilitation, and the doctors that we have, the cancer rehabilitation doctors that are part of our team, are just phenomenal at making sure our patients have 360-degree care prior to them showing up to the table. So you're starting from above, right? Any surgery will, temporarily is a temporary shock to the body. So the higher you're starting up from, the more reserve you have so that you can recover quickly from surgery. And with that approach, traditionally patients would, stay in the hospital for weeks, and they would be, have a miserable time in the ICU, and it's very different now. We do all this stuff, and patients are walking the next day. They're getting around. They're, a lot of times they're out the door within a week, and it's because of that stuff those procedures and rehabilitation that we do prior.
Just want to add on that I want to give credit where credit is due. We have a fantastic anesthesiology, Dr. Carla Cordova. She started an anesthesia protocol for the Hipec patients. And these patients actually is what helped us, these patients to get extubated even after a 12-hour surgery. And these patients get padlocks before the surgery, which basically they infiltrate the nerves of the abdomen. So when they wake up the next day for surgery, they can move around and they are not in pain from the incision that we did. And in addition to that, she managed control throughout the surgery, the electrolytes, the, you know, all the blood samples, everything that they start doing checking of the gas that they are exchanging. So we maintain these patients so monitored during the anesthesia, and we don't overload them with fluids, which really help us to get these patients moving faster. There is a time under the Hipec that we need to flush the kidney with liquid, but we wait for that moment, for that specific, that's a control moment when we do fluids and make the patient urinate. But besides that, we maintain a very strict control of the fluids, and mostly on the dry side.
Question coming in from the audience. What chemotherapy is used in Hipec, and are there any side effects of the chemotherapy?
Well, let's start with Dr. Villamizar, his chemos he uses, and I answer last.
The one that I use is cisplatin, and the main adverse reaction is the toxicity to the kidneys. But with the protocol that we have, honestly, I haven't seen the first patient with kidney problems at out of my patients.
For me, I use, it depends on the cancer type and it depends on the patient. So for mucinous cancers, when we do Hipec for them, we use mitomycin C. And then when it's for standard ovarian cancer, we traditionally have been using cisplatin. And recently there's been data to combine it with Taxol at the time of the Hipec as well, because the Taxol stays in the peritoneal cavity. It doesn't go to your body. So you don't expect to see significant toxicity, additional toxicity from the Taxol, because it doesn't go elsewhere. With the cisplatin, the doses that are used for peritoneal malignancies are lower than the doses for pleural malignancies. And so honestly, with the protocol that we have, the ERAS, the prehab, making sure we have good patient selection, I've never seen any kidney damage with Hipec, and we do a lot of these. And so it's all about, like I was saying earlier, doing your homework prior to the operation, and you end up avoiding a lot of these complications. But then like abnormalities happen and third spacing happens, and that's why we send the patients to the ICU. We monitor them, hypoglycemia, hyperkalemia, the electrolytes, like I said, you know, sometimes patients have to remain intubated rarely, or there will be pleural effusions, but those are all things that we anticipate, and that's why the patient goes to the ICU the first 48 hours, is essentially to monitor for these and to treat them, anticipate them, try to prevent them from happening, and then treat them as they happen right away.
That is correct. We use different chemotherapies based on the disease. If we are treating a mesothelioma, we're going to use cisplatin. The same as Dr. Villamizar uses for the mesothelioma in the chest is the same that we use for the mesothelioma in the abdomen. And we have different medications that we give to protect the kidneys when we use cisplatin. For most of the mucinous, for the pseudomyxoma peritonealis, for the mucinous tumors from the appendage, goblet cells, the colons, we use mitomycin C. For gastric parenchymas, we use a combination of oxaliplatin, cisplatin, and mitomycin. Those are the protocols there are. For colon cancer naive that they haven't had chemotherapy, we use a combination sometimes of leucovorin 5-FU and oxaliplatin. That's a different protocol, but in reality, they are very similar to the mitomycin C. So it's very few patients that really we use that protocol. For round cell tumors, we use doxorubicin. We have done very few here because it's a very, very rare tumor. It happens very seldom, but we have had some of those patients and all go through those. Now, with mitomycin C, what I had noticed is in some patients, if they have different type of IV chemotherapy before, sometimes they can have around day 5, day 7, the bone marrow gets depressed and they go into decrease of the white blood cells and the red blood cells. but we are already prepared if that happens. We're monitoring the patient, so when that starts happening, we catch it early on and we start working on making sure that not only monitoring, but if they go below a threshold, that we start giving medications to stimulate the bone marrow. But that's one of the few complications that happen. Most of the things really, the good thing of the Hipec is because you're giving, it's a regional chemotherapy, right? You're just giving it into the abdomen. So you can give higher doses of medication and with less side effects because you are not giving it to the entire body. There is a small portion that gets reabsorbed, but that's what minimize the chemotherapy side effects per se. Now, somebody that has been in surgery for 12 hours and lying flat on their back, obviously they're gonna build fluids around the lungs. Like Dr. Sinno said, there will be pleural effusion. Sometimes we tap them and drain them, sometimes we don't. But the whole thing is that we want to stay always a step ahead of whatever potential complication can happen, so we can catch it up early on.
Dr. Moller, a patient goes through cytoreductive surgery in Hipec. How long are they in the hospital for on the average? And then what is the recovery like at home?
Well, like we explained, usually the patients are in the hospital for about 10 days. Some, like I say, some patients can go earlier, some patients can stay longer. If a complication occur, obviously they're going to stay longer in the hospital. But somebody that went through it and flew through it, usually around 8-10 days. Usually what we expect is return of bowel function and that they are able to eat again, to send them home. Obviously with nutritional support when they go home as well. What was the second part of the question? I'm sorry.
The recovery period at home. When can they go back?
Oh, that's usually, the data, and it's very similar in most papers that you notice and we see in our patients. Patients will go back to where they were 3 months, about 3 months. So 12 weeks later after the surgery, they should start feeling where they were before the surgery, if everything went well. So they regain the strength, they regain the energy level, they're starting to have more acquainted with the way their body and intestines are working based on how much intestine we had to remove. But it's usually about 12 weeks after the surgery.
Okay.
For Dr. Sinno and Dr. Villamizar, I think maybe it's slightly different, especially for Dr. Villamizar, I think.
Okay.
Yes, so for us, the main problem that we have with pleurectomy, meaning removing this lining of the lung, is the air leak. So, typically we keep those patients intubated, connected to the ventilator machine overnight. And then the following day, we do a bronchoscopy, meaning go inside the airways and clean all the secretions. And then we remove them from the ventilator. The patient stays in the ICU typically about 3 to 4 days, mainly making sure that there are no arrhythmias in the heart and that kind of thing. But once we, the patient recover from that, then the rest of the hospital stay is going to be dictated by the air leak. So I put 4 different tubes in the chest to control that air leak. And then after 5 days, I start to remove 1 tube at a time, depending on which tube is having the air leak and which one is stopped already. And that is what keeps patients in the hospital, for several days and sometimes several weeks. And I think similar to what Dr. Moller was saying, is about 3 months probably that they take to recover at home. And just going back to this prehabilitation program, I use the same exact analogy that Dr. Sinno was using. I tell the patients, this is not robotic surgery like the machine that I have here in the back, where you should expect those to be 1 night in the hospital and then just go home, and then you can be frail, but we can get you through it because it's minimally invasive surgery. This is not it. You are going for a marathon. It's not like a little sprint and then in and out of the hospital. They need to be ready and committed to a very intensive rehabilitation program. So I typically put them not only before surgery, but right after surgery they have to go to a pulmonary rehabilitation program. And it can take up to a year to get back to actually feeling like they can, do the kind of exercise, that the intense activities that they would do before surgery.
Glenn, one of the things that we always tell our patients regarding complications is that, I will say, I speak to ovarian cancer specifically, the benefit from surgical debulking and having radical cytoreductive procedures, meaning if the tumor is on the liver, doing the liver surgery, and not just limiting yourself to the pelvis, like going after every speck of tumor. The benefit of that has been shown over and over and over again in our literature. So especially when it comes to ovarian cancer, the difference between even 1 centimeter residual disease or no residual disease is in the order of years. So we're not talking about something minuscule, especially when it comes to our cancer. So like many, many months of difference between a suboptimal debulking, meaning someone who has gross residual disease, or someone who has a complete resection. The difference in survival is dramatic. So the idea is that, can we get the patient through this radical operation or this aggressive operation? But the Hipec is additive to the cytoreduction. So the majority of the complications that you will see, if when we see a complication, it has to do also with the surgical aggressiveness and that is needed for the long. So it's kind of short-term pain for long-term gain. You need to perform these procedures that have an inherent higher complication rate. Like clearly, your chance of having a bowel leak is higher when you resect the bowel versus not resecting the bowel. But if resecting the bowel means you get to no residual disease and added years of life, then that risk, everything in medicine is risk and benefit. So there is absolutely an inherently increased risk of complications with radical cytoreductive surgery. But the idea is, and this is what our data shows as well, is that at the 12-week mark that Dr. Moller was talking about, or the 8-week mark for the most part for ovary cancer, are there significant delays in commencing chemotherapy? Is the patient back to baseline? And while the route to those 8 weeks or to that 12-week point might be a little rougher after you do this, at that mark, most patients, we find them anecdotally and in the literature, are doing pretty much the same. And the benefit in terms of survival, you've kind of invested in that sense. So there's definitely complications, but if you can get them to where they need to get from a debulking point of view and a Hipec point of view, then that's worth it.
Yeah. And I would say that I think since we have so much experience, we have done so many hundreds of patients by now, we are very aggressive. And I think we are more aggressive than most places, I would say, because I think the expertise that we have gained have make us be comfortable what somebody may not consider resectable. Once that we evaluate the patient, actually it becomes resectable. And I think it has to do with the level of skills and experience that we have. And the beauty of it is, like, in a lot of cases, we work together. Like it could be the same patient, and is Dr. Sinno, we also had Dr. Chatvich from urology that work with us. We have the colorectal surgeons, myself. In some cases, if the tumor is in the diaphragm and we have to resect, Dr. Villamizar come and work with us as well. So we work together on this. So everybody brings the best of their skills on the same patient, and it's multiple teams. Sometimes you will see that room is 20 plus people in that, and multiple machines that we use. We all use different tools, but it's a team effort. And then it's not just the surgeons. We have amazing nurses in the operating room that help us to take care of these complex surgeries, because it's a very intense. Like if you imagine how a transplant surgery is with so many teams and so many pieces that need to put together, is very similar in a Hipec. And we have a dedicated nurses that work just for these cases, so they know exactly what we need when we need it. And I would say that the work that they do is marvelous as well.
Last question coming in is, can people be cured with cytoreductive surgery and Hipec? For
certain tumors, yes. The answer is yes. There are, especially for low-grade mucinous adenocarcinoma, neoplasms, pseudomyxoma peritoneal, if we are able to get an R0 resection, we can get a disease when it's early on. The data show that about 25-30% of the patients can actually be cured. And for other patients, we can extend the disease-free survival for more than 80% of the patients being alive without disease at 5 years. Like I said, it will depend on the histology of the tumor. There are mucinous tumors like the goblet cell tumors that the numbers are not as strong as those other ones. But there are three things that the Hipec does. One, in a subset of patients, it can cure them. And another subset of patients can make them live longer without disease. And a third set of patients is a palliative option when nothing else is working and we just need to palliate their symptoms, their ascites, and do a debulking to just improve the quality of life, knowing that we are not curing them, but that we are trying to extend the lifespan. So I would say, obviously, we don't have all the time to go in details right now, but for different histologies, those survivals are different. Those cure levels, there are other tumors that are at higher percentages. And obviously, I would say everything, and even our own literature, our own data shows that the quality of the cytoreduction is what really, really makes the big difference. And the Hipec come and help us to maintain that success. That's for my diseases. I let Dr. Sinno and Villamizar tell us about their expertise in that.
Dr. Villamizar?
Yes, so in terms of the cytoreductive and high or heated chemotherapy in the chest, which would be like the high tech, I guess, instead of the P put in the T for thoracic. We have like these two very different histologies. We see the mesothelioma, which is a very aggressive tumor, and then the thymoma. So the numbers in mesothelioma also depend on the type of mesothelioma. So there are like three different types of meso, which are the epithelioid, the sarcomatoid, and the one in the middle, which is the biphasic. So people with epithelioid mesothelioma, particularly young patients, it is possible to cure them, but the numbers are low. And the analogy that I learned from my mentors where I trained is that what we try to do is reset the clock. We are, removing all this tumor basically with the idea that now you start from zero, and if it comes back, you still are gaining all these years, and hopefully by the time it comes back, there is a new therapy like immunotherapy or something that they can give through the blood that is going to cure the cancer at that time. So that's what we try to basically encourage our patients to do. Now, in terms of thymoma, that is a very slow growing tumor. So that's the beauty of doing these cases in thymoma, which I think that probably a great majority of these patients can be cured, because it's going to take so long for this to come back that it is unlikely that they're going to die from the disease once we debulk them.
For ovarian cancer, I will say you cannot overcome disease biology with surgery, right? So in the upfront setting, our intention is curative in the first line. So the patient is, got diagnosed, and she's getting after neoadjuvant or the initial surgery to be followed by surgery. Our intention is curative. Hipec has not been shown to improve cure rates for ovarian cancer, but it has been shown to improve time to progression and overall survival in the neoadjuvant setting. And then there's a plethora of retrospective studies that show that improves time to progression in the recurrent setting. That being said, the opposite of the question is true, the opposite question is true. Like, can someone who is otherwise curable stop being curable if they don't undergo a proper operation for debulking? And the answer for that is yes. So surgery will not cure you, but having an inappropriate or less than complete cytoreduction or suboptimal significantly impairs your chance at cure. But no, to answer the question directly, Hipec does not in and by itself cure patients. It's the overall treatment between surgery, chemotherapy, heated intraperitoneal chemotherapy, and then most importantly, molecular testing and targeted therapy afterwards. So with ovarian cancer and PARP inhibitors, we're seeing in a certain subset of patients with molecular alterations of homologous recombination deficiency, those patients are more curable than ever before. But there's no way to answer this in a shorter way, but the answer is.
But what I will add to that is that peritoneal carcinomatosis is just an umbrella, right? So, but people sometimes say, well, my friend has this done and this happened. It depends on the type of tumor because there are multiple tumors, they behave different, they have different biology. So each individual, if we do subset of different tumors, will be different. So no, each person is the same. What is important is that patients get referred early on to an institution, like in our case, like ours, when we had the expertise and the experience, so we can actually evaluate these patients properly and give that chance either of curing it or resetting the clock for the disease. Like I say, we always give the benefit of the doubt and try to do the best we can to make sure that we don't rule out patients. Of course, there will be some of them that we won't be able to help, but the vast majority of patients get helped, and especially if they get referred early on.
Okay, doctors, we have no questions coming in. I'd like to thank our audience for attending our Q&A session tonight on Hipec and treating peritoneal carcinomatosis and thoracic carcinomatosis. And doctors, thank you very much for your time, and have a pleasant weekend.
Thank you very much for having us. Good to see you.
Thank you very much.
Thank you for having us.
It was great. Thank you.
Thank you.